Hi students, how are you? Enjoying your lockdown period? Now we will be going through the mechanism of normal labor. Normal labor by definition is the delivery of a live term fetus via naturalis spontaneously. All the words in this sentence is very important. So if there is two fetuses or more, it becomes abnormal. If it is an IUD, it becomes abnormal. If it is preterm less than 37 weeks, it becomes abnormal. If it doesn't come through the via naturalis, it becomes abnormal. And all instrumental deliveries are abnormal. So once more to recap, normal vaginal delivery is the delivery of a term live fetus via naturalis unaided. As all of you know, the 7 cardinal movements in the mechanism of normal labor is descent with increasing flexion, engagement, internal rotation, restitution, external rotation, delivery of the shoulders, and then the delivery of the rest of the body. The 3 forces that come to play in the mechanism of labor or in a vaginal delivery is the passenger, who is the fetus, the passage, that is the hard bony maternal pelvis as well as the soft tissues, and the force, that is the power, powerful uterine contraction, and the second stage straining by the patient. Here we will be dealing today on mechanism of normal labor. So the passenger, it is the vertex presentation or the engaging diameter is suboccipitobregmatic. In a well flexed head, it is called vertex. The engaging diameter is the suboccipitobregmatic, which is 9.4 centimeters, and in engagement, the biggest transverse diameter, that is the biparietal diameter, has to pass the pelvic brim. Now we will be doing the mechanism of labor in an LOA position. Usually the biggest transverse diameter in the pelvis in the brim is the transverse or the oblique diameter. So the fetal head tries to enter the pelvis in the oblique diameter. In an LOA position, the fetus back is on the left side and the limbs are on the right side. And in vertex presentation, a well flexed head, before the head enters the pelvis, the first pelvic grip, it is a hard, round, ballotable mass, and the occiput is at a lower level and the sinciput is at a higher level, and it is 5/5 palpable. When the occiput tends to enter the pelvis, it is 4/5 palpable, and in the first pelvic grip, it is a hard, round, non-ballotable mass. So the first cardinal movement is descent with increasing flexion to facilitate engagement. Posterior fontanelle is now in the anterior quadrant of the pelvis, that is the left anterior quadrant, so it becomes an LOA, and the sagittal suture is in the right oblique diameter. So with increasing contraction, the denominator in a vertex presentation is the occiput, that is the lowermost part that is palpable from below in your pervaginal examination. So by engagement, we know that the greatest transverse diameter has negotiated the pelvic brim, and the denominator occiput is at the level of the ischial spines. So the third movement is internal rotation. Due to the peculiar configuration of the pelvic floor and the gutter-like nature of the urogenital diaphragm, the denominator, when it touches the urogenital diaphragm, that is the levator ani, it rotates medially and anteriorly. The main principle of internal rotation is that the biggest diameter in the brim was the transverse diameter or the oblique diameter, and the biggest diameter in the outlet is the AP diameter. So the fetus tends to adjust to enter the brim in the oblique diameter and to come out of the pelvis in the anteroposterior diameter. That is the basis of internal rotation. The factors that facilitate internal rotation is the elastic recoil when the occiput touches the levator ani, the ischial spine impedance, as well as the pelvis. All these contribute. Good gynecoid pelvis where there is space in the anterior quadrant, all this favors for an internal rotation. After the completion of internal rotation, the occiput hitches against the pubic symphysis, and by a process of extension, the head is borne out. So the vertex, forehead, face will slip out of the perineum, and the transverse diameter that distance the perineum is the bitemporal diameter. Here at this stage you realize that the second stage of labor has occurred by noting the anal aperture opens up, vagina gapes, and there is crowning of the fetal head. In crowning, the scalp that is seen doesn't recede in between contraction, and here the secondary powers, that is the pushing effort of the mother, takes place in the second stage of labor. And in only normal labor, extension occurs for the fetus to come out. Rest all abnormal labor, it is delivered by flexion. The twist that had occurred to the neck due to the internal rotation undo, and that is restitution. So what happens is that the occiput goes back to the original position. So the occiput faces the left side of the mother's thigh, and the face faces the right side of the medial aspect of the mother's thigh. Now the shoulders enter the pelvis, that is the acromion diameter enters the opposite oblique diameter, that is the left oblique diameter, and external rotation corresponds to the internal rotation of the shoulders. So first the anterior shoulder which hits against the pubic symphysis, and the posterior shoulder sweeps down the perineum, and then the anterior shoulder slips out. Rest of the baby just slips out. In normal vaginal delivery, actually the restitution and external rotation occurs so fast that we will not be able to see these movements. But when there is difficulty in the internal rotation of the shoulder, we go to a condition of shoulder dystocia, which will be dealt to you in later classes.